Bueno, damos entonces comienzo a la siguiente sesión, que es el Simposio ViiV. Mi nombre es Isidoro Prudente, soy el director médico de ViiV Healthcare y quisiera especialmente agradecer a VILA por la oportunidad de participar en esta gran reunión que año a año nos permite tener un foro de discusión sobre VIH y un foro de educación médica continua. Así que para nosotros es un gran placer. En esta oportunidad hemos invitado al profesor Giovanni Guaraldi, que ya fue presentado a todos ustedes de la Universidad de Módena. Y el tema que vamos a discutir junto con el profesor Guaraldi son los desafíos que aún permanecen en el tratamiento del VIH y cómo los regímenes de dos drogas pueden contribuir a los mismos. Muchas gracias.
And so I promise is the last talk, and so I will not bother you anymore, I promise. Okay, let us start from here. I already presented you. This is our program, what WHO tell us about how we need to manage people living with HIV for the next decade. Okay, and what is shown here is that we discussed. That is the cascade of care. Okay, but there's something new in this cascade of care. It was not new unless there were some comment here. The comment here says, mind you, the cascade of care has got as an objective the possibility to achieve a good health-related outcome. And mind you, in order to do so, we need to have a patient-centered health service. And so what is suggested is that something must be changed. The way in which we perform the care is changing. Okay, actually this document was also before some new scientific advances that we will discuss today that really tells that it was visionary to say the healthcare model needed to be changed now, because it's not just enough to reach viral load and detectability, we need to reach good health-related quality of life. And I told you to reach a health-related quality of life, and you need to have a patient-centered health service. That is, that you need to introduce patient-reported outcomes as if it was a biomarker, as I collect viral load, I collect the quality of life. This exactly what it says. But there's even something more that is interesting. That is, mind you, here, there are what they are called additional key outcome. That is, rapid treatment after diagnosis, okay, engage differential and chronic care, and achieving a good related quality of life. Okay, so this is a ViiV Symposium, and so actually what I will be doing now is to contextualize some of the incredible ViiV research into this framework and try to understand how can the drugs, and in particular, of course, in these symposiums, the ViiV drug, help to meet this fourth 90%. I already told you that we do not expect that any drug solve all our health, our quality of life issue, but definitely can help to ameliorate some health-related quality of life issue. Okay, what was written, it was that the cascade of care really depends on rapid art. Well, are we sure about rapid art? And so are you doing rapid art? And so in the first section, someone says, oh, we can do rapid art, we cannot do rapid art. And so actually the data are not that consistent. We know that rapid art in resource-limited country is for sure something that enable the engagement of the patient, the retention in care. And so, actually, mind you, I've been working as a junior doctor in Tanzania. I was part of the scaling up of antiretroviral, and actually, before putting a patient on antiretroviral in the early at the end of the century, what we were doing is to be sure that the patient may be adherent, he had to return in order to be sure that we were not giving drug in a patient that was not adherent, especially if he was coming from a village, and so on and so forth. And so it took months for a patient to demonstrate adherence before he actually could get the drugs. Nowadays, in my center in Tanzania, you get HIV testing and you get out from the room with your Dovato therapy. That's funny. Okay, why we believe that there's drugs that can help us? Actually, we've got two great studies that actually enabled us to say that rapid ART is something that we can obtain, and we can obtain with two-drug regimen. And so all this data you have already seen many times, that this is the Gemini 1 and 2, and actually Latin America was the continent in which really the dogma of three-drug regimen was broken forever. And actually what reassured me is really the long-term follow-up. And so we are speaking about 144-week follow-up in which we are able to sustain this virological suppress, and we will get into detail. But what was even more striking to me is that is a rapid ART feasible with Dovato, even when you do not have the measured viral load. You don't even know the serology of HPV. And of course, this was really very striking with regard of 0 cases of treatment-emergent resistance mutation. That was something that actually was worrying us in the time in which this trial was designed. And so actually, I believe that we've got a good level of evidence, both in treatment naive, we already mentioned the Gemini and the START trial, but also in the two virological suppressed trial, that is Tango and Salsa, in which we can say that the two-drug regimen met the non-inferiority criteria for primary endpoint, but also were able to have such a huge long-term follow-up, 144-week, 196-week, that puts the randomized clinical trial exactly in the same perspective of a real-world evidence data. Of course, we've got data about virological suppression in patients with a very high viral load, and also what is most important to make all this be very clinically oriented, the possibility to have information about diverse patient demographics and characteristics, and what is important for me for elderly people entering HIV care or switching to care. Well, what we know is that with regard of Dovato, the number of drug-related adverse events, and especially the adverse events that lead to discontinuation, were in fact very low. And to me, this is very important, because in the patient perspective, is side effect that worries the patient, both in the short and in the long term. But of course, as a doctor, as a clinical virology, what is really worrying is to say, what about the genetic barrier? And so is it true that 3 drugs is better than 2 drugs with regard of obtaining high genetic barrier? And of course, this can be seen according to the numbers of resistance mutation that you accumulate in such a long follow-up. I always knew very little about mutation because I never remember that. And so I've got some colleagues that are very expert in mutation and take joke of them to say, oh, you've got a lot to say when you presented this data, because the result is always 0, 0, 0, 0. Okay, and so that is to say, nowadays, of course, a difficult to treat patient do exist, okay, but actually this is the effect of the long history rather than the current treatment that we do provide. But nevertheless, adverse event and genetic barrier is not enough. You need to demonstrate the third pillar of an effective treatment that is called is called, in fact, robustness. And robustness is an idea that, at a clinical level, put all this issue together. And so, what is the genetic barrier? But what is the forgiveness? And so, to what extent I'm able to sustain virological suppress in a situation which is not unusual of different level of adherence. And so actually the robustness is something very difficult to demonstrate, but really start on how can I detect the forgiveness of a drug. It means even if I skip a dose, will the drug fail or not fail? And actually there's a different reason why a drug should guarantee you forgiveness. Some, and this is the case of Dovato, is really intrinsic in the pharmacokinetics of the two drug regimen. And so 3TC and DTG were a perfect marriage because of the fact that their half-life is exactly the same. If you stop the drug, you get to 0 for both of the drugs. And this, it means that the pressure of the drugs get to 0. And that is why you will not have an exposure to one of the two that will represent the risk for the selection of mutation variable. And so that is why we believe that we've got now proven long-term high barrier to resistance in more than 280,000 patients that have been experienced. And actually this is shown on the fact that in turning from randomized clinical trial into real-world evidence, this is a US study. It's not a very large study, but it's an interesting study that really tells us that any switching from a 3-drug regimen to a 2-drug regimen actually do not lose anything with regard of the robustness of the drug. This is a second study from the Spanish group. But go back. Why we're speaking about that is because of the virological concern about that? Not that much. Actually, most of the time, whenever I decide when to move from a 3-drug regimen, I'm not dealing that much about the genetic barrier or all these issues. I'm trying to say, is there something at a biological level that tells me there is an advantage? Okay, and of course, a demonstrating advantage whenever the viral load is undetectable is difficult, because of course you start from undetectable viral load and you keep undetectable viral load. But actually, is there something that will inform me if, I don't know, it's a good reason to keep tenofovir or TAF in this regimen, or switching to a non-INSTI regimen will help me. And so actually, from a pathogenesis point of view, and again, you know, I'm very fond about aging. Of course, we know that HIV infection is associated with a biological watch. And so we know now that there's also different biological watches that can be used. The most important is, of course, the methylation of DNA, but also that we know that that HIV trigger event associated with aging, and actually people with HIV, of course, may also have their own contribution because of unhealthy lifestyle. Most of our patients are still smoking, do not exercise, maybe are poor, and for this reason do not have a proper diet about this. And of course, this means that even at a cellular level, you can recognize an aging condition. And actually this may be associated with autophagy, with different signal issue, but also with metabolic dysfunction. And let me say, have I got any issue that can help me to intervene about chemokine and cytokine and oxidative stress intervention? No, so far, the only issue that I can manage all these issues is a meta-inflammation approach. What I can know is that I can downregulate inflammation if ever I'm able to correct the metabolic derangement at a cellular level, at a patient level. And though that is why my clinic is still called a metabolic clinic, but actually what is dealing is aging. But why? Because actually the best way I can do in order to reverse the aging cell is in fact to correct the metabolic pathway. And this is what EACTS guidelines suggest us. Please look the many different metabolic diseases that affect the liver, the bone, the kidney, the heart, the lung, the brain. And actually this is what we are called. And so at this point, there's a different approach, as I told you. In the past, we were looking what was the contribution of drugs with regard of toxicity, or what is the contribution of tenofovir on bone health, or bone fracture. What is the contribution of abacavir on cardiovascular disease? Nowadays, we need to change a bit the perspective. We need to have a movement in which we do not discuss about diseases, but rather we discuss about health. We do not discuss about a metabolic diseases, but we discuss about a metabolic health. But what is metabolic health? Metabolic health is like a journey in which there is something that get against the metabolic derangement associated with aging. And so I'm running against the metabolic derangement of aging in order to improve my metabolic health. And of course, it does refer to my body weight, to my lipids, to my glucose, insulin resistance, and metabolic syndrome. But I'm not just looking at comorbidities, but I'm looking to empower my patient to achieve the better metabolic health it can do. And so actually, I've got to change a bit the way in which I measure it. Okay, and so nowadays, just to give you a flavor about that, I like to use something that can be measured at an organ level. I want to discuss metabolic health. You know what I do? I take a FibroScan and put in the liver, because the liver is my metabolic organ. If I see I've got high fatty liver, it's not just a liver condition. I know that fatty liver is associated with central visceral adiposity. I know that fatty liver and central fat is associated with insulin resistance. And insulin resistance is at the basis of any aging condition. Imagine diabetes, imagine cardiovascular disease, imagine neurodegenerative diseases. And so the idea is that whenever I now treat what now I'm calling metabolic associated fatty liver disease, because I want to stress that what I find in the liver is in fact a polymetabolic condition, implies the fact that the first intervention is patient empowerment. The first guidelines is just to reduce 10% your body weight, 5% your body weight. And so this is to say, can I do something in order to improve the metabolic health with regard to the environment, with regard to the proper selection of drugs, and maybe to avoid what is not needed. I don't want to get into detail, but I can tell you that whenever I compare 2 drug regimen with 3 drug regimen, I may have non-inferiority, and of course I may gain something with regard of the negative metabolic effect of tenofovir, or rather TAF, that of course we know has been associated with kidney and bone disease. But I was telling you, something is really changing. And to me, the cornerstone of this is the REPRIEVE study. Okay, and so I was so much enthusiastic about the REPRIEVE study. Along when it was going, I was already trying to capture what is the best, and you know that the REPRIEVE study was stopped because of the fact that there was a disproportional good effect with regard of 35% reduction of myocardial infarction, of MAGE in people with low cardiovascular risk, and even more, a 21% reduction in the composite endpoint of MAGE and overall mortality. And so mind you, We know that nowadays we need to consider the number to treat whenever we want to think how to offer statin to our patient. And mind you, in the person whose ISCVD score is 5%, the number to treat is 30. And so it's extremely cost convenient to provide statin in order to reduce. I treat 29 patients in order to avoid one myocardial infarction. But let me say, what was the most striking result of reprieve? It was the gender issue, the sex issue that was found. There's no difference in MASH event in women when compared to men. And so go back to say, does the risk estimator we were discussing before works in people with HIV? Never. But in particular, they don't work in women. And so the point is that nowadays, there's something that I need to consider. I need to consider that statin to get, the reprieve tells me to discuss every time the lifestyle counseling to all the patients. And statin, according to guidelines, and I think I've got no guidelines. I can tell you that VIVA guidelines, the DSH guideline, and nowadays shortly you will see the EARCS guidelines recommend to consider statin to all people living with HIV, but really recommend to use statin to all people in which the cardiovascular risk is above 5%, mind you, regardless the level of LDL. And so this is important. We offer statin not because LDL is high, okay, but we will monitor LDL as an outcome of statin therapy, and the new target will be to all people living with HIV less than 70 milligrams, and in people with secondary prevention, less than 55. And so is this reachable? Well, it is reachable according to the antiretroviral therapy you are taking at the same time. Because if you are taking a PI, this will never be possible. Okay, what I can tell you that appropriate choice of statin make this target be reachable. But why actually we want to do so? I told you that the reprieve make a difference because the reprieve now tells us that antiretroviral is no more the standard of care in people living with HIV. The new standard of care is antiretroviral plus statin or plus any other metabolic active agent that reduce the chronic inflammatory state. And so this is the novelty of the treatment. Go to your student and ask how you treat people living with HIV with antiretroviral therapy. Wrong. It's with antiretroviral therapy and metabolic active agent. So far, we've got two evidence. One evidence is statin use. The second evidence that is coming very closely now is the GLP-1 agonist result. And so the point is that we know that statin, apart from a lipid-lowering effect, in fact, act at the hallmarks of aging, actually are able to reduce the prothrombotic issue, the immune activation issue. And so altogether, we antiretroviral as well as statin work together in a geroscience propriety. It means that we are acting in order to make the biological age of people living with HIV turn to be similar to their chronological age. This is extremely interesting because it's for the first time that we can say, even in people that are perfectly treated, in which we are not worried about the durability of the adverse event, of the robustness of the drug, we will add a new option. Actually, I need to confess, I don't know if I can tell you, but actually, ViiV some times ago, just the week after the reprieve was published, called some of us in a private meeting asking if what was our opinion to put pitavastatin inside the Dovato in a fixed dose combination. And we were joking to say, oh, are you longing to have a 3-drug regimen again? But the third drug is not a third antiretroviral, but rather pitavastatin. And it makes sense, of course. It's not something practical because, of course, how to use a statin is something not obvious. I need to know what are the long-term risk of statin use, the short-term risk, how to manage myalgia. I know for sure that statin do not worsen sarcopenia. That's a good issue. I know for sure that actually I need to have different statin use and different statin dosage, hydrophilic statin, like for instance, atorvastatin, lipophilic statin, like for instance, Crestor, and how to add with other compound. And now we've got bepenoic acid, which is of course something very interesting also to couple to statin again. And so lots of things is changing. But I'm in an aging setting. And I told you, how can I revert frailty? Let me say, in a situation in which I will always have drugs, okay, I will also add statin up to the age of 75, at least. These are the data that Reprieve gets us from 40 to 75. Well, I know that the more drugs I use, the worse it is. And so how can I combine this? I'm adding drugs, but I know that the less drug I have, the better it is to revert frailty. And so actually, I've got the data that tells me that 40% of people that are above the age of 65 experience polypharmacy, and this is a problem. And in AIG's guidelines, we told that whenever you've got polypharmacy, there's 2 issues that you need to be worried about. One is drug-drug interaction. The more drug you have, the more interaction you expect. But also, and this is more difficult to tackle, is the inappropriate drug prescription that occur when you get older. Well, drug-drug interaction is easy with regard of Dovato. If these are data from the Liverpool database that tell us that among all antiretroviral therapy, Dovato is the less likely to have any kind of drug-drug interaction. That is easy. Choose easy choice. But what is more interesting is to say, well, how can I de-prescribe? So I've got a patient, he's got myocardial infarction, he's got diabetes, and so definitely he will have 10, 12 drugs above antiretroviral therapy. There's 2 ways. On one side, I know that there are drugs that should not be used in older people. And so we put in the AIG's guidelines that the top 10 drugs that should not be used in elderly people still are very much used. Imagine alpha agonist for prostate hyperplasia that actually produce fall because of postural hypotension, and fall produce fracture, and fracture produce disability. Okay, of course, it should not be used. But mind you, there's another way that is a pruning back. It means can I choose a little by little, one by one, each drug, what the benefit is when compared to the harm, and you will realize that a lot of drugs can be taken away. But actually, my approach was like this. And so if the polypharmacy affect all the drugs, why don't consider that affect also antiretroviral therapy? And so whenever I have a patient who is older than 50 years that have got polypharmacy, I need to discuss, is there an advantage to de-prescribe drugs? All drugs, including antiretroviral therapy. Can I get rid of all antiretroviral? Definitely not. But what is the wording I recommend you to think? I'm not telling you, can I simplify the regimen? No, I'm telling you, can I de-prescribe? De-prescribe is a unique geriatric word. It means that I take out something to gain quality of life. And so if I use this word, it means that I'm doing something to improve your quality of life. And isn't quality of life my ultimate goal? And so what can I do if I've got a poly pill with regard of antiretroviral? Well, I've got 3 strategies. I can have a single tablet regimen, and most of the company now is offering a single tablet regimen. Very good. Okay, I have a 2-drug regimen, that is going into, let us say, a more geriatric approach, and this can be oral, okay, and they've got two oral combination, that is Dovato and it is Juluca, or rather moving into long-acting combination. But mind you, if I do so, I expect to have at the very bottom some result with regard of quality of life. And these were, in fact, the quality of life measured that were done in these studies. And I already showed you that the patient preference goes exactly in the direction that the prescribing antiretroviral therapy improves quality of life domain. So this is my last question, and I truly believe that we are entering a new era. It's so beautiful to think that we are not just the manager of antiretroviral, but we are managing the chronic inflammatory process through metabolic pathway. Okay, I had no time to discuss what the result of semaglutide. All my patients have got visceral obesity and they are normal weight most of the time, and it's the first time that the semaglutide is able to reduce 30% central fat, just reducing 10% my body weight, and that's really never seen before, okay? But also all the issue regarding statin and this. And comorbidity and polypharmacy are daily obstacles to treatment success. We need to treat, and Dovato, in combination with statin, will become a standard of care in the roadmap to achieve metabolic health. The prescribing and therapy, including ART, is an objective in the care of people living with HIV to increase health-related quality of life. Thank you so much. And the last slide is a scientific paper published in Nature that tells me that if you listen to me so much, I definitely have bored you. Apologize for that.
Muchas gracias, profesor Giovanni. Y creo que tenemos algunos minutitos para preguntas, así que abrimos a preguntas para el profesor Giovanni. Tenemos una pregunta aquí. Dr. Shehad Abdallah.
Okay. Thank you very much for this very informative lecture. My question with the elderly, with the people living with HIV, old age, on polypharmacy. And I noticed from your slide that the interaction between dolutegravir containing regimen versus competitors is less, the drug-to-drug interaction. So the drug-to-drug interaction when you use dolutegravir containing regimen versus other competitors. So can you comment on this as a reason to switch or start from the beginning dolutegravir containing regimen?
Yes, and so DDI is something difficult to manage. And so just to remind you, we've got an excellent drug that very few people use. This is Paxlovid. And still we had a lot of people that died because Paxlovid was not properly used by GPs. Okay, and why? Because they were afraid of DDI because of ritonavir contamination. And so again, this is an example just to say DDI worries the doctors a lot. Okay, you know that actually I was a pioneer in the transplant setting. When I started, I had just, there was no INSTI, I had just protease inhibitors, and I had to manage the interaction with tacrolimus. I was giving 0.1 ml of tacrolimus every 10 days in order to have appropriate dosage of that. And so, mind you, DDI are harmful. Okay, and for this reason, either you are very much skilled, either you use very good tools in order to detect all this, or it's better to avoid. But what really worries me is that I'm always surprised on the fact that the patient takes many more drugs that I do not know. And more they get older, they may go to other specialists, and most of the time other specialists either don't know about HIV status and antiretroviral medication, or they do not care about sharing information about that. And so we are working about also electronic and artificial intelligence way to collect the drug reconciliation list. And so shortly, we will have also tools. What we ask the patient now is to take pictures of the boxes that they have and refer us. Actually, we've got an artificial intelligence way in which if you take the picture of the barcode of the boxes of the drugs, you can immediately upload in your electronic patient chart the list. And for us, it's also very much time consuming to do all this. And so that is something that I suggest you to implement in your clinic. But definitely we need to do. There's another issue in the young people we are very much worried about is the issue about chemsex. And it's a lot of chemsex in our setting, especially in Northern Europe, but also in Northern Italy. And so again, whenever I choose a drug with limited drug-drug interaction, I keep in mind I don't know exactly what the patient is taking, and there are a lot of recreational drugs that may be very harmful whenever I choose. And so this is a reason why I feel much more reliable whenever I choose a drug combination that have got no drug-drug interaction. Okay.
Innanzitutto grazie. Gracias por la presentación. Nos tranquiliza a todos saber que lo que hacemos todos los días en el consultorio, de tomarle la presión, de pensar si tiene pequeñas alfombras con riesgo de caída en la casa y cuidar a los pacientes desde lo clínico, forma parte del cuidado de las personas con VIH. En este contexto, en lo personal, yo, Elena, me siento tranquila y relajada indicando rosuvastatina. El Reprieve está hecho con pitavastatina, nosotros no tenemos en la Argentina, y el acceso a las estatinas debe ser muy irregular según los países, ni hablar de costos. ¿El resultado es equivalente? Esa es la gran pregunta. Gracias.
So I'm not worried about different statins, and so I believe that, and it's not just me, there's a great consensus to make the idea that statin as a class will work, and mind you, the statin effect, as I explained, is twofold. One fold is reducing the LDL level, but the second fold is reducing the gene expression of genes that are associated in hallmarks of aging. And so that's the beauty of this issue, is that we are entering a geroscience era in which we are able to give drugs to reduce age as a disease and not just reducing the disease that occurred in aging. And so that is a totally new perspective, and it's very interesting. Mind you, you mentioned that you may have different access to statin. Now what is important that every one of us learn how to better use a statin at which dosage. What we know is that Reprieve is asking us to use not low, but rather moderate statin effect, okay? Still, I need to understand what is moderate according to the patient risk, okay? And so it's not just I put pitavastatin inside a fixed dose combination. No, this is an opportunity, because when I prescribe statin, I engage the patient about lifestyle changes. And so it totally doesn't make sense to say, I give you a statin without asking, are you smoking? Okay, and so that's the big opportunity is regarding to that. Nevertheless, mind you, statin are drugs. And statin, what worries me is not rather the muscle pain. Actually, it's overestimated. Actually, I joke, but this is the true story. Since the publication of the New England Journal of Medicine, I started studying myself because it convinced me. And so I explained this to the patient, okay, that, yeah, it's something that changed my mind, okay? And I'm totally well, and of course, I need to tell the patient, if you do not tolerate statin, we've got bependonic acid. We don't know all the information of statin, but bependonic acid already have a New England Journal of Medicine paper that demonstrates that it does reduce mortality. And so that's very good. But again, what worries me is statin implies that you know the level of insulin resistance of your patient. Because I've truly recommended to use atorvastatin rather than rosuvastatin if you've got insulin resistance, because a mild increase in insulin resistance is provided by rosuvastatin when compared to atorvastatin, okay? And mind you, try to use the appropriate dose. Do not use very high dose if it is not needed, because there is a dose effect with regard of insulin resistance. But what we know from large trial in HIV-negative individual is that the co-occurrence of diabetes in people starting statin is because at the beginning there is a common metabolic pathway that drives contemporary to diabetes and cardiovascular disease. A big issue is, again, to discuss this with the weight gain, and we know that the best way to reduce insulin resistance is to have a weight loss in people who are obese, but also in people who are overweight with central visceral obesity. And so another very easy issue to give is ask the patient to measure waist circumference and try to use that as a standard in order to reduce the risk.
I think no more questions. ¿Alguna otra pregunta? Consulta el Dr. Giovanni. I think this is your last talk for the day, so make the most. Aprovechen que está aquí el Dr. Giovanni si tienen alguna otra consulta. Bueno, parece que no. Entonces, doctora Fanny, lo siguiente es el lunch, ¿sí? El almuerzo. Y no sé si quieres dar algún comentario, un housekeeping note.
Bueno, muchas gracias por el simposio nuevamente, el doctor Guaraldi.